Hello everyone, it's Abdullah here, and we're going to cover a few of the trauma setting scenarios. And this will include extradural hematoma and subdural hematoma and how to deal with them, and also how to manage the intracranial pressure. And then we're going to move on to maybe some abdominal trauma, including liver laceration and also splenic rupture as well. And also, we're going to end this by talking about some fractures, including the pelvic fracture and maybe a spine fracture as well. So starting by extradural hematoma, we have a 23-year-old male patient presented after a road traffic accident, GCS is 15, and he vomited 2 times and then suddenly dropped the GCS up to 8. So from this scenario, we need to consider that our management will be basically based on A to E approach, as per the trauma management. And very quickly, I'm going to go through the A to E approach in trauma setting, and that would be a generic approach for any trauma patient. So starting by the airway, the key word in the airway would need to be patent and secure. So patent means the patient is able to talk comfortably and doesn't have any sort of shortness of breath or doesn't have any sort of a stridor or shortness of breath. That means it's patent, and obviously there is no foreign body inside. In terms of secure, that means the airway doesn't have any sort of compromise. That might lead to that. The scenarios that I always use for a secure airway or a non-secure airway is patients who had burn. This can lead to swelling of the soft tissue in the upper respiratory tract and can lead to compromise of the airway in a bit. The second thing is, the other scenario is maybe thyroid or neck surgery patients who developed hematoma in a wound following this. They might lead to compromise of their airway as well. So A is the airway plus C as well, and C means C-spine. We need to make sure that C-spine has a 3-point stabilization or immobilization. And that would be by using blocks and also a tape and maybe a neck collar as well. So that's in terms of the airway diagnosis and treatment as well. Of course, if the airway is not patent or not secure or patient GCS is less than 8, we need to secure this airway. The airway adjuncts that we can use, we can do some maneuvers. And this can be head tilt, chin lift. I'm pretty sure you all know this. And also jaw thrust maneuver. In addition to the maneuvers, we can use some other airway adjuncts. And that would be using an airway support or airway adjuncts. These can be divided into 2 different things. Into a definitive airway and a non-definitive airway. A non-definitive airway is such as Gadel or oropharyngeal airway or a nasopharyngeal airway. This is sort of a transition until you get a definitive airway in place. And the difference between a non-definitive and a definitive airway is the glottis. So this one is supraglottis, above the glottis. Definitive airway, it's infraglottis, and that will be the endotracheal tube, whether it's a cuffed, has a balloon, or a non-cuffed endotracheal tube, and also tracheostomy. Alright, so we need to assess the airway and make sure it's patent and secure. And I'll know some example for a non-secure airway. and then do 3-point immobilization for the cervical spine, and then treat the airway by doing some maneuvers, head tilt, chin lift, and also using some airway adjuncts could be definitive and non-definitive. And the non-definitive is an oropharyngeal airway and a nasopharyngeal airway, and the definitive is endotracheal tube and tracheostomy. There's also a non-definitive airway such as the laryngeal airway. Still supraglottis, but has a better grip on the glottis or the epiglottis, and this will make it, better, slightly better than oropharyngeal and nasopharyngeal airway. Moving forward to the breathing. And in the breathing, we're basically assessing the ventilation, if this patient is getting adequate oxygen to their body or not. This can initially be done by using a pulse oximeter. And here we're trying to assess the oxygen saturation. Right? After we have assessed the oxygen saturation, we can do a quick chest exam. Basically, you're doing an inspection, you're getting a respiratory rate, and in inspection you're looking for shortness of breath, presence of peripheral or distal cyanosis, or use of accessory muscles of respiration. Assess the respiratory rate, you check by palpation the chest expansion, and the chest tenderness anywhere for rib fracture. Okay, and also auscultation. And by that we're looking for any decreased air entry. And in particular, for chest exam, to rule out tension pneumothorax. As tension pneumothorax is a clinical diagnosis, that will be shift of the trachea. So we need to check the trachea by palpation, and also hyperresonance on auscultation, and absent air entry on one side, which it has a tension pneumothorax. Okay, we're not done with breathing. We can also consider, while doing the breathing, getting an ABG and getting a chest X-ray if it's available. All right, but this should not delay your diagnosis. So that all what we just mentioned will help you to diagnose the breathing. But to treat it, you can start your patient on oxygen. And obviously, if you find a reason, such as pneumothorax or tension pneumothorax, you can treat it by needle thoracotomy. So insert the biggest needle that you have in the second intercostal space in the mid-clavicular line to decompress the pneumothorax. So this is in terms of breathing. Okay, and then we can move into circulation. And in circulation in a trauma setting, we basically assessing bleeding. So we need to rule out bleeding, and we'll always mention it: bleeding in the floor and 4 more. So in the floor means this is an external bleeding, and 4 more means bleeding in the chest or the mediastinum or a hemothorax or around the pericardium, around the heart. Bleeding in the abdomen, so examine the abdomen for being tense or very tender. Bleeding in the pelvis, and this can happen due to pelvic fracture, and also bleeding in the lower limb, checking the calf muscles and the thigh muscles as well. So 1, we try to rule out bleeding in all these areas. And 2, we need to insert 2 wide pore cannula. After inserting cannula, 2 things, as always, or actually 3 things. take bloods, and start resuscitation by giving fluid. And as long as you're giving the patient resuscitation by fluid, think about catheter, inserting a urinary catheter. Okay, so this will be the circulation. The circulation, we can consider something called fast scan. This is an ultrasound, and you're doing it to look around the pericardium and in the pelvis as well, and around the lung and in the abdomen, toward the spleen and the liver as well. That's a fast scan. So this is how to diagnose and treat the C as well. And then we can move to the D, or disability. We're doing quick neurological exam. Basically, you're trying to assess the Glasgow Coma Score, or you can do the AVPU if you don't have time. Okay? In addition to that, we can get temperature measurement, and also capillary blood glucose. So that's in the D, and if there is any issue, we can again start treating it as well. So for example, hypoglycemia, we can give by getting the hypo box and starting our patient on dextrose 20%. And then in terms of the E, that will be exposure, and then the exposure exposing the whole patient and examining the back as well for spine. Following that, we can take a quick ample history, and that's asking for the allergy, the medication, the past medical history, the last meal that the patient had as well. So this is a quick introduction on how to do an assessment for a trauma patient or a polytrauma patient. All right. So we have a scenario in here, like we explained earlier. A 23-year-old male patient presented following a road traffic accident with a GCS of 15. He vomited 2 times and there was sudden drop of the GCS. This is a CT scan. What do you think of this CT scan? So the way we can present the CT scan, this is an axial cut of this patient that is showing right temporal hyperdense biconvex lesion, and this is showing a mass effect. And the mass effect is always 3 things. If you look here, you can still see some of the sulci on one side, but here effacement of the sulci. You can't see any sulci around it, so that's effacement of the sulci. The other thing is you can see some sort of a change in color around this, and this is edema. And the edema here is called cytotoxic edema. There is also compression of the ventricles and the midline shift. So that's all of the mass effect. And this is how you always are supposed to present a CT scan or MRI brain. So we have a right biconvex hyperdense temporal lesion showing a mass effect, which is represented by surrounding edema, effacement of the sulci, midline shift, compression on the ventricles, and this is likely an epidural or a right temporal epidural extradural haematoma. All right. Great. Advantage and disadvantage of doing a whole body CT scan in this scenario. So let's assume the patient is polytrauma, or actually it was an R to A. So doing a whole body CT scan, it can be very helpful and quick in diagnosing the patient, but it's a very high dose of radiation. When to consider a CT scan for this patient? CT head scan generally for any patient with a polytrauma. So there is some guidelines from NICE on how on when to consider doing a CT head. Okay, and this is classified into within 1 hour of the presentation and within 8 hours of the presentation. So within 1 hour, if the patient presented to you with GCS less than 13, on the initial assessment, we need to get a CT scan immediately. Or if GCS less than 15 after 2 hours, again CT scan. Any sign of depressed skull fracture or base of a skull fracture, okay, to get a CT scan immediately. If the patient had a seizure or had more than one episode of vomiting, or there is any focal neurological deficit. So again, 2 are based on the GCS and 2 are based on the trauma and then neuro, all right? If GCS is 15 on arrival, get a CT scan immediately. If GCS is 13, 2 hours after arrival, plain CT head immediately. Trauma, such as base of a skull fracture and depressed fracture. Neuro, it's a focal neurological deficit or seizure or vomiting after the presentation. All right? So these are the things to guide us on ordering a CT scan immediately on delivery. We can do it within 8 hours in the extremity of age, and that would be more than 65 or less than 1 year. Okay? If the patient had any history of clotting disorder or being on any medication such as warfarin or direct oral anticoagulants, or there is a dangerous mechanism of injury, that's another thing, or patient had more than 30 minutes retrograde amnesia. All right? What is Cushing reflex? So Cushing reflex is a triad of hypertension, bradycardia, and increased ICP. So basically what happens in the Cushing reflex, if the patient had trauma, there is something called Monroe-Kelly doctrine, all right? Monroe-Kelly doctrine. And this is basically the skull is a closed box. And this closed box contains a few things inside it. That will be the brain tissue or the brain parenchyma, and there is some CSF inside the brain as well. Okay? And also some blood vessels, veins, and arteries. So this is a closed box. Any increase in any of these structures, whether the blood vessel, the CSF, or the brain tissue, will lead to a significant increase of the intracranial pressure. And this, consequently, to maintain a good cerebral perfusion pressure, so there is another thing called cerebral perfusion pressure. And this equals the mean arterial blood pressure minus intracranial pressure. So basically here we're trying to measure the amount of blood that will go into the brain. So we measure the blood pressure, the mean arterial blood pressure minus the intracranial pressure will give us the cerebral perfusion pressure. So the patient had an increase in the intracranial pressure. To be able to maintain a good cerebral perfusion pressure, what we can do is to increase the mean arterial blood pressure. And the body will be able to compensate that by increasing the blood pressure, hypertension, and the patient will have some bradycardia as well. So the Cushing reflex, it's a physiological response of the body due to increase in the intracranial pressure, and this is represented by hypertension, bradycardia, and increased intracranial pressure. In epidural hematoma or extradural hematoma, there is an interval called the lucid interval. So what happens is, it's a temporary improvement in the patient condition, in patients with epidural hematoma condition, followed by sudden loss of consciousness with drop in the GCS. So this is called a lucid interval. Management of epidural hematoma. So like I said earlier, we need to manage this patient according to advanced trauma life support. If GCS is less than 8, you will go to the airway and do an intubation, stabilize or immobilize the C-spine and assess the B and assess everything as you go. So intubation will be needed, and then for further treatment, escalate to the neurosurgical team to do an evacuation of the epidural hematoma. And usually patients with epidural hematoma will get good improvement after evacuation of this hematoma. So indication of intubation in this patient is 1, decreased GCS, or in other scenarios, if the patient is unable to maintain an airway, whether the airway is not protected or not secure, like we explained earlier, that would be another indication of intubation. To maintain adequate ventilation as well, that would be another indication. And also, if you would like to sedate the patient to avoid an increase in the intracranial pressure, we can do an airway intubation as well. If they had seizure, or they have bleeding per mouth, or they have mandibular fracture or maxillofacial fracture, that would be another indication. So the basic concept here, if the airway is not patent or not secure, all right, if it's not patent or not secure, this is an indication of intubation. Not patent, not secure, that means decreased GCS less than 8. And if the patient has a maxillofacial trauma, or if there's any sort of foreign body, you can do a tracheostomy and things like that. And also, we talked about sedation, and this is to maintain a good intracranial pressure, because basically coughing and being in stress can increase the intracranial pressure. So sedation to relax all the muscles and prevent the reflexes could be a good idea to decrease the intracranial pressure. As simple as that for the MRCS level. However, there are lots of other details regarding the intracranial pressure management, and we're going to go through it very quickly in the next video as well. Thank you very much.